Great, wonderful. So I'm Dr. Munjal. There are a lot of doctors new who joined my session first time. So it's a bit quick introductions. From my side, I'm a hemato-oncologist and bone marrow transplant fellow in Ahmedabad, Gujarat. And there are a lot of doctors joined from Dubai as well. So let me tell you, I'm coming next month to UAE as well. So those who are interested, we can definitely meet in person, and we'll come up with the new programs and a lot of exciting things in Dubai next month. I am a clinical hemato-oncologist and transplant fellow and have a good, quite rich experience of treating the patients close to 20 years and treated more than 100,000 patients and delivered almost close to 100,000 lectures as well in last 20 years. So I would make this session absolutely interactive. This is our second excellent pediatric player, Dr. Arti, Dr. Maddie. Most of you knows them, right? Those who are in coaching. He is a internal medicine based at Oman. Dr. Ankit is a gastroenterologist who is also now delivering the gastrology, gastroenterology, and hepatobiliary lectures for our team. Dr. Shikha based at Dubai. She is consultant gynecologist with the Esther Mainland Dubai. So she is our one of the coach in gynec. So surgical, medical, gynec, pedia, even surgical and ortho is also there. So recently there are three doctors joined. This is our team. Three doctors. Dr. Mariam Hilad yesterday took a lecture. Dr. Sonal Shah, who is an emergency physician in a reputed hospital in India, in Mumbai, and Dr. Ismail is also surgeon and orthopedician in Oman. So these are our quite nice team of doctors who are regularly delivering the classes on daily basis and every Sunday as usual. You know it is a mock test by me on Sunday. This is our book, PROMETRIC 1000 MCQ book. Let me tell you, we are updating this as well. So probably in a month or two, you gonna come up with the latest edition with new more questions, answers, explanations, and lot more things. We have main three specialty coaching, hard copy book, and online subscriptions. Compiling all the three things under one roof, you get a combo offer. So those who are interested, you get a good discount on this. Also, we do the data flow. So anybody wants any help with the data flow, let us know. Last but not the least, we recently created one new mock test module. So still I'm seeing that there are very less people are practicing mock tests. So I strongly recommend you do the maximum mock test by which you get to know where you are doing the mistakes, how much is your score before going for the exam. You can do the self-assessment and lot more things. And we already launched the EMREE residency program as well last year. So we are planning to launch season 2 in Dubai next month. Dental MCQs are also we are preparing shortly with the dental experts. So probably in a month you have a dental access as well. Those who are near and dear and your friends. These are the various package, which is I mean absolutely a huge discount. So you go through it. Last but not the least, I mean this is the website uh, clubbed up with the mobile application. So right, you can use both the things, mobile, complete mobile. This website you can use on the Android as well as an Apple, and it is compatible with the website. So whole the website can be accessed from the mobile application. So if you have Android or iPhone, you can download the app from the thing. This is the logo on Android as well as an iPhone. Look at the medical MCQ for all. You get complete website on your fingertips. Recently updated and lots of updations are there in speed and look and feel. So you will enjoy. And last slide I just recently added. So very going very quickly and then jump to the our MCQs. Why we cannot crack the exam or what's the reason? I mean, these are the tentative reason why we cannot crack the exam. Or sometimes like these are the tentative reason why doctors cannot crack the exam. So this is I mean just all practical you must be knowing, but just to make it more clarity on this, I'll just let me quickly enumerate one by one. Unauthentic study material. What do you mean by unauthentic study material? Means many a times we are relying on the Facebook, relying on the Instagram, relying on the many platforms which probably not authentic, with no answers, no explanation, no reference, no picture, ECGs, slides, nothing, right? So we just rely on them, right? And if the same question comes, we answer as per the website, and probably we end up with the trouble. So you need a definitely a strong study material which really helps you. And second thing is the lack of mentor. You don't have any mentor, so what happens from day one, right? You need a good mentor who can guide you how to prepare, what to prepare, what kind of questions will come in exam, what are the high yield topics and subjects, blah blah, right? So random preparation is not absolutely helpful. Lack of time management, it's absolutely one of the cornerstone of the cracking the exam, because I have recently couple of doctors today joined to share their feedback who cracked the exam recently. In last 1 week, 3 4 doctors cracked from our group, so they will share their experience. And few doctors I'm talking, they said that, sir, I have 20 question left, 30 question left, 40 question left. So there is a high chance that you may end up with some failure, because out of 150 question, if 30 40 is left, means out of 110, you have to correct at least 90 to 100 questions, which is little difficult out of 110. So you need to have a timetable. Fortunately, there is no negative marking, so you can answer right or wrong, answer all 150 questions, right? So if you answer all 150, there are increased chances of getting or cracking through the exam. So time management is extremely important. You must try and practice from day one. Lack of everyday's timetable, that is also important, because when you don't have any timetable, you probably end up with some time wasters, right? So time management is absolutely, and I strongly recommend you get away from the social media. Believe me, that will tremendously save your time. So get away from the social media at least for 1 or 2 months, until and unless you crack your exam. You see it. I don't say that you absolutely delete it, but it's in your absolute leisure time, when you have done with your timetable, with your preparation, with your 100 200 MCQ a day, then you open up. But don't try to, because 5 5 10 10 minutes, it will eat your at least 1 to 2 hours a day, right? So just make some 5 10 minutes properly when you are free, absolutely you done with your job, then you probably look at this. But it's not important. Try to concentrate on your goal and dream. Taking premature exam date, that I have seen many doctors, those who are like taking the date, right? So they feel that, oh, just walk in and we can crack the exam easily. It's not like that, believe me. So you need a definitely preparation. Doctors are asking me, sir, what is a tentative time to prepare for the exam? So let me tell you little timetable as well very quickly. Those who are full timer, what do you mean by full timer? Means they are absolutely preparing for job only. Sorry, exam only. Full timer. So they need 6 to 8 weeks, maximum 6 to 8 weeks. Absolutely, they can crack the exam. Absolutely, it is achievable. And 90% plus doctors who crack the exam, they are in the job or in the practice, right? Hardly 10 20% are full timer and preparing. So, and those who are not a full timer, not a full time, probably you take a 2 to 2.5 months of time to prepare for your exam, right? Goal for full timer is to do at least 200 MCQ a day, and those who are not full timer, at least do a 100 MCQ a day. It's a quality MCQ is all available on our website and every platform, right? In every module subject wise, so you can go through it, right? And that's it. Another is not touch in the academics, because I have seen many doctors, 5 years, 10 years, 15 years, they are not in touch with any academic. They never opened up the book, and they feel that, oh, I'll go and crack it. It's not like the way. I don't want to disappoint you, but this is fact, right? It's a overall statistic I gathered of at least close to 9,000 doctors who already enrolled in the company. Being in the comfort zone, so get out of the comfort zone. Nothing you can achieve in the comfort zone. You need to absolutely work hard to crack any exam, believe me. Nothing is easy, nothing is easy. So you need to at least work hard properly on your dream and goals, right? Excusitis, don't make excuse why I can't do it, why I cannot prepare it well, why I cannot crack it, right? Get out of the comfort zone and get out of the excusitis. That is again a big disease, and it's, I think it's a pandemic disease. Every world, every corner, people have excuses. So get out of the excuses. Overconfident, underconfident, that is also a very important factor why you cannot crack it. Overconfident, you may fail. Underconfident, you may get failed. So good, have a good self confidence. And lack of dream, so you must have the dream. Without dream you cannot achieve anything. So that's it. This is what the thing is. So probably I something may probably relates to you. Out of 10 points, probably 1 2 3 points or maybe more than that can be right? So you just work on it on yourself, right? So if you do it well, then it's done. So let's start with the first questions in front of your screen, our main things. 59 years old man comes to the physician because of 1 week history of gingival bleeding and worsening fatigue. He has also had a decreased appetite and 5 kg or 11 pounds of weight loss over the past month. He has tried over the counter vitamin supplementation with no or minimal relief. He appears pale, probably is anemic. His temperature is 37.8, pulse rate is 72, blood pressure is 120 over 70. Physical examination shows numerous pathological lesions over the upper and lower extremities. A bone marrow smear is shown here. Which of the following additional finding is most likely in this patient? Not get in hurry. We'll discuss each and everything in detail with the concept, not just the mugging up the answer. So just to get you little more idea about the smear, I will share a bigger picture. So you probably had a better idea with these slides. Yeah, sorry, huh? Something went wrong. Yes. So this is a smear. This is a smear in front of you. You look at the smear, and if you want to see the history, this is the history. So you see the history. If you want to see the smear, this is smaller picture of the smear, this is larger picture of the smear. So this is the history. Before jumping into the diagnosis, I will give you the tips and tricks in each and every MCQ. And as you know, right, those who are, we solve at least 10 MCQ in this, 10 MCQ minimum. All your leukemia is done in this slide. Complete leukemia. Any queries is welcome. So we need a three answers in this question. What it could be the diagnosis, how we gonna investigate, and what could be the treatment. So in every MCQ, those who are attending first time, in each MCQ you need to ask yourself three questions. Here they had probably not given you the answer. They had given you the bone marrow smear. So on bone marrow smear, you need to make some kind of diagnosis that this could be a diagnosis. So this is a smear. So you look at the smear, try to give the answer what it could be, and then we'll discuss. Then we'll discuss. Then we'll discuss. Yes. Anybody wants to comment, they have the chat box facility, right? If they're shy, they can put their answer in the chat box, right? So we can discuss one by one and we try to solve the problem. Somebody is saying, Dr. Sidra, am I audible? Can anyone say? Can anyone confirm? Am I audible well?
Yes, sir.
Yes. So somebody is saying I cannot hear you. So I think my voice is clear. Yes, you can think of your answer. I'll give you 5, 10, 15 minutes. Think of your answer. Yeah, I did not get so far any comment in the chat box. So I would be glad and happy if you can post something right in the chat box. Let me know what is your diagnosis. If the same question comes in your clinic or to your practice, right? What you gonna do? What it could be? First, without diagnosis, you probably may not get the clear cut idea. This type of questions are nowadays coming in the exam, not a one liner. So you need to stress your mind and you need to exercise a bit more preparing for your exam. Yes, anyone, post your answer in the chat box what it could be. It is aplastic anemia, it is lymphoma, it is myelodysplastic syndrome, it is leukemia, it is iron deficiency, it's a B12. You have history, you have everything. Yes, Dr. Nirja, have you seen this bone marrow slides? Dr. Nirja.
Yes, sir.
So what do you think if this patient clinical context comes to you in your pathology department, how you gonna react or what you can see in the slide? Can you see the slide well? Yes or no?
It's like a blast. These are looking like a blast.
It's looking like a blast. So when
Yes.
looking like a blast, what could be the diagnosis? If you see the blast in the bone marrow
Mm.
blood, what it could be?
It's like
Infection,
so
leukemoid
few of
reaction, sorry.
it's like leukemia. Few of the blast shows like all rods like things.
Okay, excellent. So at least you hit the things. So when there is a or rod, what could be the diagnosis? Is AML or ALL or
AML
CML or
only,
CML?
sir. It's AML.
So first of all, the take home message, write down everybody, right? Or rod is equal to AML. Or rod is equal to AML. You cannot see in CML, you cannot see in CLL, you cannot see in ALL. These are the four types of leukemia. So we'll go gradually, right? How leukemia diagnosed, how it's done. So this is very excellent pictures here, right? If you can see here in the center, there is a this is a cell, and
Yes.
within the cell, you can see a odd rod like a structure in the cytoplasm. This is a rod, yellow rod. I'm just showing just to get you little more ideas. This is all rod. So whenever the rod in the cytoplasm, it is called, first of all, it is called or rod. And or rod is none other than AML. So this patient is suffering from AML. That is for sure, 100%. So whenever you are dealing with the AML or you see the rod like a structure in the cytoplasm of the blast cell, it is AML. It is none other than AML. This is very basic concept, right? So this is one AML, right? Now further question, right? How many types of AML? How many types of AML, doctor? Can you tell me? How many types of AML? There are hundreds of questions in this, and people are confused. Yes, Nirja, have you come across this FAB classification or anyone? It's
Uh,
open for all.
yes.
Yeah. Yes. So what is the classification of ALL?
ALL, sir. It's like ALL,
No, no,
L1,
we are
L2,
talking about
L3.
AML. No, 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 no. We are talking right
AML,
now AML. Yes, AML because what are
M0 to
missing in AML?
M7, sir, total.
Okay, so M0 to M7. Let me write down
M7.
M0 here, M7 here. So can you tell me what are the names of M0 to M7?
M0 means
M0 is
undifferentiated.
undifferentiated. M0. M1 is M2,
M1 is specific
M3,
differentiation.
M4, M5, M6, M7. So this is for everyone.
M7.
There are at least 50
Mm.
questions, 50 in this. What I'm explaining is 50 MCQ, equivalent to 50 MCQ. So first of all, FAB is a French, American, British classification, right? And this is recommended internationally. So whenever you open up the book, everything will come up after my lecture. So undifferentiated, this is minimal differentiated. This is completely differentiated with
Mm.
maturation. This is called
APML.
acute promyelocytic AML, APL or APML, acute promyelocytic leukemia. This is myelomonocytic
Monocyte.
leukemia. This is
Monocytic.
monocytic leukemia. This is erythroleukemia,
Erythroblast.
and this is megakaryocytic leukemia.
Megakaryoblast.
So these are the seven names. If you remember, I would be happy and glad. So this is one thing which you need to know. There are seven differential. There are M0 to M1 seven subtype of AML. How you diagnose this? By the morphology of the cell, by the immunohistochemistry, and by flow cytometry or immunophenotyping. This is how it's classified on this basis M0 to M7. So any patients you have AML in your clinic or in your leukemia ward or in hematology or ICU, you must ask what kind of or what is a subtype of AML. This is called all subtype. Main type is AML. This is a subtype. Why we need to know this? Because there are lots of implication and lots of clinical things attached with this. Now, number one question. All M0 to M7 options are same. If I can ask you, what is the commonest in terms of incidence and prevalence? Highest incidence of which AML? Highest. Highest incidence of which AML? Remember, M2.
M3.
Second question. Options are same. Option M0 to M7. Which
Mm.
AML to M0 to M7 has the best prognosis?
M3.
This all are
M3 has
question.
best prognosis.
Sorry, M3. APML
M3,
M3
sir.
has the yes,
APM.
M3 has the best prognosis. Second thing, which right, this is associated with translocation of 15 and 17, right? And
Mm.
it is
Yeah.
treated by ATRA, all trans retinoic acid,
Sure.
vitamin A dairy. This one liner is absolutely 3 4 question. Number one question, which AML subtype has best prognosis? M3. Which AML M3 has which cytogenetic abnormality? Translocation 1517. Right? Translocation 1517 acts against which drug? ATRA. That's it. So these all are the high yield question. Which has the worst
Mm.
prognosis? Second question, worst prognosis. Worst prognosis. Worst prognosis. Or this is AML M7 as very rare as well as worst prognosis,
Okay.
right? Worst prognosis. So these all are questions related with the AML. So we have seen the AML. What is AML? AML is all rod. This is how we diagnose. There are 7 subtypes. This is what these things, right, clinically implicated, right? So this is the thing. So now let's get back to the questions again. Now you get to know that this patient has rod in the cytoplasm, and you get to know that this is the AML, sir. Now, and now look at the question. What is the question now, right? So what is the question now? So this is AML. Why? Because there is rod in the cytoplasm. So now this is out of the 3 wings. As I draw the 3 wings, what is the diagnosis? So we reached up to the diagnosis. Now this is AML. Now look at the next things. So this patient is a 59 years history of gingival bleeding, means some kind of low platelet. These all are the classical sign. Elderly male, elderly AML usually seen in elderly, right? Because of low platelet, he has a bleeding. Worsening fatigue. Why fatigue? Because of low hemoglobin, probably they have not mentioned, but he must have low hemoglobin. Constitutional symptoms is the weight loss, right? He thought that this fatigue and this all because of some kind of vitamin or iron deficiency. So he tried over the counter, but he has no relief. He appears pale. Why he appears pale? Because he has a low hemoglobin. Low hemoglobin, you check in the conjunctiva, tip of tongue, you check and you do the examination in general examination. Mild fever, 100.6 is mild fever, but the vitals are not bad. Pulse rate is okay. Blood pressure is so this patient is not in the shock. Petechial lesion. Petechial lesion. Why petechial lesion over upper and lower limb? Because he has a low platelet. That is why petechial lesion. So patient has a low platelet count, patient has a low hemoglobin, patient has a blast cell which contains the or rod in the peripheral smear or bone marrow. It is none other than AML. That's it. This is how you have to interpret in the exam, right? Each and everything we will dissect today, right? So AML. Now what they are saying, which of the following additional finding is most likely in this patient? So what you can see in this patient, right? Right? Are you going to see translocation 972? Are you going to see
No,
positive
sir.
heterophile antibody? Are you going to see peroxidase, a positive granule? Are you going to see cold agglutinin body, or you can see follicular hyperkeratosis in this patient? What you want to see in this patient?
Peroxidase positive granules.
Wonderful, wonderful, wonderful. Peroxidase positive granule. So what is peroxidase positive granule? So let's see. So this is a case of AML,
Microperoxidase.
and they are asking which of the following additional finding. So let me tell you. Can anyone tell me translocation 922 is seen in what condition? It's a
CML,
very lollipop question. Yes,
Philadelphia
doctor.
chromosome.
Excellent, wonderful, brilliant. So Philadelphia chromosome, it is called pH positive chromosome, Philadelphia chromosome. The oncogene is BCR-ABL is an oncogene, and drug associated which blocks the BCR-ABL or tyrosine kinase inhibitor is called as the imatinib. Is that clear? Yes or no? Tell me at least yes or no. Yes or no?
Yes, sir.
Wonderful. So translocation, right? It is seen, right? And this Philadelphia chromosome, let me tell you, we have every day coming in our OPD the things. 90% of the patient, have a pH positive chromosome, right? Only 10% does not have it, but they have again the BCR-able, right? And very rarely patient is a pH negative and BCR negative. This is called as a atypical CML, atypical, where both things are absent. But it is extremely rare. I'm treating hematology, but rarely once a year I'm seeing such a patient. Those who are pH negative and BCR negative, able negative, 99% of them they have pH positive and BCR able positive CML, chronic myeloid leukemia, and where you don't see any OR rod, right? You don't see a or rod like the way you see or rods in the cytoplasm, the rod like structure. This is a nucleus, so this is or rod like structure you cannot see in this. So CML is the not diagnosis, and in CML you see the translocation 922. Is that clear? Right. Second thing is peroxidase. What is the peroxidase? Can anyone tell me what is the peroxidase positive granule? What exactly it means? What do you understand by peroxidase positive granule means what?
Usually, myeloblast contains myeloperoxidase, which is positive for the peroxidase.
Fair enough. Fair enough. Fair enough. And where you see the cold agglutinin antibody? Cold agglutinin antibody. You are in the lab and somebody says, sir, cold agglutinin body is positive. What does it mean?
Cold
Mean
agglutinin hemolytic anemia, which is
IgM
hemolytic
anti.
anemia possible. Great, wonderful. So it could be in the cold agglutinin antibody. It's a warm as well as cold, right? So two type of this agglutinin bodies. Fair enough. So that's it. So the answer for the sake of the exam point of view, positive myeloperoxidase or peroxidase positive or myeloperoxidase MPO positive. So I'll give you the definition and head-to-head comparison. Don't worry. So next slide would be this only. So this is the answer here for this question is myeloperoxidase seen in AML, not in ALL, right? So let me before jump to this. This is absolutely brilliant, right? Picture. I loved it. So I got it from the journal. This is a stem cell. Understand this, then hundreds of questions and query will be solved. Until and unless you understand basic, you always gets confused. So stem cell is the main cell, or you can say hematopoietic stem cell. This stem cell is like a mesenchymal stem cell. This is a hematopoietic stem cell, which gives eventually rise to all blood cells in the body. So this hematopoietic stem cell will eventually differentiate in a two cells, lymphoid stem cell and myeloid stem cell. And lymphoid stem cell, simply there are two cells mainly developed by the lymphoid, right? Is this all three, right? But at least B lymphocyte, T lymphocyte, and natural killer cell. And B lymphocyte is eventually form the plasma cell. And if I go in detail, plasma cell develop the five types of antibody, which is IgG, A, M, D, and E. This is called as immunoglobulin. And immunoglobulin, right? It's a kind of antibody, right? So this is all antibody production, right? So when there is acute infection, IgM increase. When chronic infection, IgGs remain in the plasma for long time, probably weeks to months and years probably as well. Right? So this is basic concept. This immunoglobulin has a this Y kind of structure, right? Which probably we forget. So this is a light chain, and this is heavy chain. This is light chain. This they are together, right? This is what the structures of immunoglobulin. That's it, right? And if it is increase in the plasma, the condition is called as a multiple myeloma. More than 10% of the monoclonal plasma cell in the blood or the bone marrow, it's multiple myeloma. So when plasma cell is at problem, it is also known as a plasma cell dyscrasia. Plasma cell dyscrasia. Have you heard of this term? Yes or no? At least tell me yes or no, right?
yes, sir.
Plasma cell dyscrasia. So plasma cell is a problem. It is called as a plasma cell disorder, plasma cell dyscrasia, and you get lot of terms in your medicine. One is a one is MGUS, monoclonal gammopathy of uncertain significance. It's a plasma cell disorder. Smoldering multiple myeloma. It is a plasma cell disorder, and eventually the most dangerous is a multiple myeloma. So we'll discuss sometime detail in hematology. So this chart will give you idea. So what? So I taught you the m- myeloma as well. What is the definition of myeloma? So presence of more than 10% of the monoclonal plasma cell in the blood or bone marrow is called as a multiple myeloma. That's it. But from where this comes, you need to know it's derives from the lymphatic system or lymphoid stem cell. So it's a lymphoid malignancy, right? From B cell, you can see a B lymphoma or leukemia. T cell lymphoma. This is all in the picture in the WHO classification. Not going much in detail, but try to understand the basic thing, right? So same way, this story is over. So when stem cell, there are two division. One is a lymphoid and one is a myeloid. So lymphoid, easy to remember, they give rise to a B lymphocyte and T lymphocyte. That's it. That's it. Natural killer cell, if you can remember, well and good. If not, then it's fine. But B and T lymphocyte and B lymphocyte eventually do the development of plasma cell, and plasma cell, right, produces the antibody which protects our body against the infection. That's it. Myeloid, there are, you can say, myeloblast, right? So myeloblast, right? So you can say myeloblast. So myeloblast will give rise to, and this is a part of myeloblast. So myeloblast or monoblast, if you cannot differentiate, well and good, myeloblast. So myeloblast will give rise to all the myeloid series, right? So basophil, eosinophil, neutrophil. This is all three cumulative called as a granulocyte. Why? Because there is a granule in the cytoplasm. Monocyte does not have granule in the cytoplasm. Lymphocyte does not have granule in the cytoplasm. So three granulocyte and two agranulocyte, lymphocyte, monocyte. But monocyte is produced by the myeloid stem cell or monoblast, right? So this all WBC except one, lymphocyte, everything is developed by the myeloblast, right? So this is WBC. This is WBC. Again, this is a platelet. So this myeloblast produce myeloblast plus megakaryoblast eventually develop megakaryocyte, and megakaryocyte give rise to a birth to platelet, right? So this is a platelet. And same way, the myeloblast eventually into erythroblast, reticulocyte count, and mature RBC. And this is RBC, mature RBC or red blood cell. So red blood cell, white blood cell, and platelet, everything developed by the myeloid series, everything by the myeloid series. Only just lymphoid or lymphocyte, B and T lymphocyte will develop by the lymphatic stem cell or lymphoid stem cell. Is that clear so far? Yes or no? At least tell me yes or no. Yes or no?
Yes, sir.
Wonderful. So this is
Yes,
this
sir.
is how, yeah, so this is how the AML, as I told you, the classification M0 to M7 develop, right? AML. So M0 is like undifferentiated, absolutely. So there is a myeloblast, there is a OR rod, but you cannot differentiate M0, M1, right? Then you can say myelocyte, right? Myeloblast, then acute promyelocytic leukemia. This is all various form. And if you know bit in detail, the neutrophil does not develop. Neutrophil directly does not develop from the myeloblast. Myeloblast to promyelocyte, metamyelocyte, band cell, and then neutrophil. This is again a detail of how myeloblast will eventually evaluate from the myeloblast to the neutrophil. So these are the steps. So if the promyelocyte increase, it is M3, right? Myelocyte, promyelocyte, metamyelocyte, M4, myelomonocytic, M5, right, this erythroleukemia M6, and this is M7. So this is how the classification happens. Whatever is at the problem, right? Promyelocyte at the problem, myelocyte, metamyelocyte, band cell, neutrophil, erythroblast, leukoblast. So this is how M0 to M7 comes in picture. So M0 to M7 all are here in myeloid series. That's it. So this is what you need to understand. If you are guys are interested more in bit in detail, I will take some hematology. That is my main hardcore subject. Anyway, so let's come to the AML versus ALL. In this slide, you need to understand what is AML versus ALL. So this is Yeah, so in AML, just you need to remember hundreds of questions asked in the various exam. Acute myeloid means myeloid means myeloperoxidase, myelo. Acute myeloid leukemia, myeloperoxidase, right? Is that clear? This is how you can remember. So this is only positive, and shortly it is known as MPO, myeloperoxidase. So AML myeloperoxidase positive, pass and TDT negative. In ALL it is reverse, right? Here it is positive, MPO positive in AML, here MPO is negative in ALL. These two are TDT and pass negative, here TDT pass positive. That's it. This is what the difference. So if you remember one, you can remember rest of the things. That's it. This is one way by which you can know that the immunochemistry, right? By staining, right? By how they get stained, right? So myeloperoxidase enzyme, if it is positive, it's a myeloid marker, it's myeloid leukemia. If it is absent, it is lymphoid. So this is you can do. Flow cytometry, you can differentiate, right? So B cell, or this is CD10, CD19, CD20. This is a marker of B cell, BALL means there are, right? Lymphoblast will give rise to two cell, B lymphocyte and T lymphocyte, and B lymphocyte will give rise to a plasma cell as we seen. So B lymphocyte markers are what? So this is CD20, CD19, CD20. T cell markers are what? CD2, CD8, CD3. If you remember, well and good. If not, that's fine. It's a job of hematopathologist, not the you, right? But just for your understanding, how do they differentiate clinically? So this is what the thing is. And last but not the least, cytogenetic in ALL, cytogenetic in ALL, how you differentiate cytogenetic in ALL. So in ALL, cytogenetic Philadelphia chromosome can also be present in 20 to 30% of patient in ALL, right? In adult and 5% in children. So CML, you get a Philadelphia chromosome in 95% of the patient, but also in ALL, in adult, you get a Philadelphia chromosome positivity 30%, and in children with ALL, you get a 5% patient, right? Why we need to know this? Because Philadelphia chromosome positive means translocation 922, means part of the 9 number of chromosome is going into the 22, and 22 numbers chromosome is going into the 22. So this is 922. So 9 part going in 22, 20 part is going into the 9, and the gene is created or a chromosome is created. That is called as a Philadelphia chromosome, and which carries an oncogene called as the BCR-ABL gene. And this BCR-ABL gene is responsible for the pathogenesis of the CML. So if you block this gene, right, it will stop the progression of CML, and drug of choice for this is imatinib. Is that clear to everyone? Yes or no? At least tell me yes or no.
Sir, in this ALL patients with Philadelphia positive, we can give imatinib for treatment
Yes,
then?
absolutely. Absolutely. It's a treatment. Wherever you get a Philadelphia chromosome positive, wherever you get a translocation 922, wherever you see BCR-ABL, you can target this. Uh, then in that case, you can give it. So there are commonly three conditions. Being a clinician, we are looking for Philadelphia chromosome CML. Another is ALL. And if you have heard the name GIST, gastrointestinal stromal tumor, where also you get this. So GIST, first line treatment after surgery is imatinib. Is that clear?
Yes, sir.
Yes or no? Right? So this is all clinical
Yes,
implication,
sir.
which we probably, being a medical oncologist, hematologist, or the things, right? So these are the things which I don't want to go in detail, but these are the absolutely high yield things. And last but not the least, excellently, you can take a picture. This is created by me. No, not single book in this world has a four under one roof. It's a various different chapter, but just for the better clarity and understanding, I put it under one roof, all AML, ALL, CML, CML. So AML, what is the definition of AML? 20% of the blast cell in blood or the bone marrow, it is AML. 20% of the blast cell, which blast cell? Here the lymphoid blast cell, here the myeloid blast cell, right? So we have seen this is a hematopoietic stem cell, and then this give rise to a lymphoblast, and another give is a myeloblast. If lymphoblast is more than 20%, it is acute lymphoid leukemia. If it is more than 20% of the myeloid blast, it is acute myeloid leukemia. Is that clear to you? Yes or no? At least tell me yes or no.
Yes,
Yes or
sir.
no? right? So if you don't
Yes,
ask,
sir.
you will miss many concepts. So feel free to ask me all tricky question. So simple definition, acute myeloid leukemia is more than 20% of the myeloblast. That is why myeloid leukemia. More than 20% blast. Which blast? Lymphoblast. That is acute lymphoid leukemia. That's it. This is the most simplest definition of AML and ALL. Right? CML usually they don't have blast, no blast, except in a blastic crisis they have blast, but which is less than 1%, and CLL there is no blast. So when there is an excess blast, you either think of myeloid AML or ALL. So in acute leukemia, blast will increase. If it is myeloid, it is myeloblast, lymphoid, lymphoblast. That's it. This is one point which you need to know. Number two, most important thing in AML, this column is of AML. So OR rod is present, OR rod is present, is in the AML, as I told you. OR rod is absent in ALL, OR rod is absent in CML, OR rod is absent in CLL. That's it. This is absolutely high yield point, right? And MPO, what do you mean by MPO? We just see now myeloperoxidase and Sudan black, both are positive. So myeloperoxidase, myelo means myeloid. So myeloperoxidase positive here, myeloperoxidase negative, MPO negative, here negative, negative, right? CNS involvement in AML extremely rare, or there is no CNS involvement. It is yes positive in ALL. That is why we are giving the prophylaxis to the children of AML with intrathecal methotrexate or high dose methotrexate. Are you agreed with me? Yes or no? Have you seen this patient of ALL, the child especially who is getting the intrathecal methotrexate? Yes or no?
Yes,
Right?
sir.
So intrathecal methotrexate is given for the prophylaxis of CNS relapse in ALL, where CML, CLL, no this neurological involvement. And treatment is all the same for acute leukemia, induction chemotherapy followed by consolidation and probably the maintenance in ALL. Here the BCR-ABL gene is responsible for CML. The chromosome is PH positive, translocation 922. Treatment of choice is imatinib 400 milligram once a day, right? He has to take. That's it. This is what the treatment is. And CLL, it is a chlorambucil CVP, and nowadays rituximab is added in this because it is anti-CD20 antibody targeted therapy. So those patient who has a CD20 positive BCLL, CD20 positive, we have a drug which acts against CD20, which prevents the growth of the leukemia. So drug against this BCR-ABL is imatinib. The drug against this CD20 is a rituximab. Rituximab. Have you heard of this word, rituximab? Yes or no?
Yes, sir.
Rituximab. So rituximab, this is how it acts and works, right? AML, the most common is AML M3 with high cure rate, and the usual presentation is pancytopenia. Here the pancytopenia usually in acute leukemia. Here the completely different in chronic leukemia. There is a high count. Here the high count. Here also a high count. High WBC count. Here the high WBC count. Here also high WBC count. How you gonna differentiate? Right here the most differentiating point is high WBC, but it is neutrophilic leukocytosis. Neutrophilic, here lymphocytic leukocytosis, right? More than 90% of the lymphocyte in blood or bone marrow. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Great. So this is, I mean, general understanding how they present one from another. Just we need to know. So if you know this chart, 90% of the time or close to 100, I mean, you get the idea because they ask, everything is given in the history. Patient has this much of blast cell. Patient has a neutrophilic leukocytosis. There is a pancytopenia, presence of OR rod, MPO positive, no CNS involvement, right, blah blah. So this is how you get to know that what it could be, the diagnosis, the presentation, the treatment. So it is under one chart. Probably this is like an easy chart which for us to remember very easily, because we have a lot of confusion. So before jumping into the next question, I would like to have any question on this leukemia, any random questions, something which stucks in your mind, but there is no clarity so far how to deal with this. I would be glad and happy next 2 more minutes to spend on this. Any question? AML, ALL, CML, CLL. Any question. Don't shy to ask. Though it's a silly question, but no question is a silly question. All valid questions. So don't hesitate. If you are not asking, means I considered that it is all good. Okay, go ahead. So this is the answer. Myeloperoxidase positive granules are typical finding in the blast cells of AML and differentiate AML from ALL, which is characterized by the blast cell that are myeloperoxidase negative in ALL. These granules can aggregate to form OR rods, and which OR rods may present with most subtype of AML, particularly common in AML M3, and treatment, as I told you, vitamin A derivatives, ATRA or all-trans retinoic acid is the treatment of choice for AML along with the chemotherapy. So that's it. Rest of the things, translocation and all I explained you. The cold agglutinin antibodies are pathogenic and cold agglutinin disease, autoimmune hemolytic anemia, you can see. It is associated with a malignancy like non-Hodgkin's lymphoma, some hepatitis, mycoplasma, right? But it cannot be seen in AML. So cold agglutinin is not the answer. Follicular hyperkeratosis is a typical finding in vitamin C deficiency, scurvy, and vitamin C deficiency causes swollen gums, gingival bleeding, which is also present in this patient. However, it would not explain any other finding like or rod in the plasma. Oh, sorry, cytoplasm. Is that clear why other answers are not there? So from now onwards, go home and do the practice. Your job is not just to get the answer. Sir, there is the answer is the myeloperoxidase. Okay, fine. It is good. I'm happy that you did that job nicely. But you need to know why not this? Why not this? So I given this is seen in CML, right? This is seen in CML 922, not seen in AML. So that is why this is not the answer. Why not this is the answer? Why not this is the answer? This is not seen in AML, or rod is not seen in all cold body. This is seen in scurvy or vitamin C deficiency, blah, blah, blah. So you need to see complete context of the question, not just one, right? Because gingival bleeding can happen in all. You can see CML with low platelet, you can see, right? You can see in AML, you can see gingival bleeding because everywhere platelet is low. Here it could be a low, right? Vitamin C, right? You can see a gingival bleeding. So, right, but in vitamin C deficiency, you cannot see or rod. Or rod cannot be seen, right? So this is how you have to differentiate one from another question, and that practice you need to do regularly. Once you do it, then you will be a more expert of this. So let's move to the next questions. So hopefully this is clear from my side because you did not ask me questions, so I thought this is done. A 40 years old woman comes to the physician for a routine health maintenance examination. She feels well. She has no history of serious illness. She works as a flight attendant. She is sexually active with one male partner. Menses occurs at the regular interval, 28 days interval with normal flow, no excessive bleeding per vaginum. Her last menstrual period was 10 days ago. She had a normal pap smear 1 year ago. She does not have any children. Her mother was diagnosed with ovarian cancer at the age of 63 years. She does not smoke cigarette or use illicit drug. She does not wish to have any children and uses oral contraceptive therapy. She has no drug allergy known and her immunizations are up to date. She appears healthy. Her temperature is normal, pulse rate is normal, blood pressure is normal, physical examination is fine, no other major things, or you can say a physical examination is essentially normal. Patient is concerned about her risk of ovarian cancer. Patient is concerned about her risk of ovarian cancer. Why? Because her mother got at the age of 63. That is the fourth line of the MCQ. Which of the following is most appropriate next step in the management with the young lady 40 years whose mother has a blood this ovarian cancer and now she's concerned about the risk of ovarian cancer. So what you gonna do now for this patient? Perform familial risk assessment using a questionnaire, recommend bilateral salpingo-oophorectomy, recommend barrier contraception instead of oral contraception, recommend annual transvaginal ultrasound and measurement of CA-125 concentration because it's a tumor marker of ovarian cancer, and you directly jump to the genetic testing of BRCA1 and BRCA2 mutation for this lady. So think over it. What you can advise to this patient now? You can give your answer. Yes, Dr. Sidra, any comment on this? Dr. Sidra, any comment?
Hello, sir. Good afternoon.
Very good afternoon. Yes, go ahead. What do you think? What you gonna advise to this patient and why?
Alhamdulillah, sir. Thank you so much, sir, for asking. Sir, because the patient's family history belonged to diagnosed with ovarian cancer 63 years when her mother. So that's why we have to perform genetic testing for BRCA1 and BRCA2 mutations. Maybe she will also suffer from in her late age. So that's why my answer just perform genetic testing.
Fine. We'll discuss the correct answer as well. So I would like to understand. Right. So now say for example, you did a BRCA1 and BRCA2 for this patient. What
Yes.
if it is positive, what's your decision? If it is negative, what's your decision? If patient, you did a genetic test for the female who is 40 years, right? Flight attendant. So now she's positive for BRCA1. Is there any change in the management? Or would you like to advise? Next question is this. This lady underwent for this genetic testing and BRCA1 is positive. What's your advice? Next question. Are you getting me?
Uh,
Yes or no? At least tell me yes or no. Are you getting me?
yes, sir, I'm getting this. Sir, after that
Wonderful.
we have special, if it is negative, then no problem. And if it is positive, then we have to do further investigations and
So,
advise.
so what further investigation you would like? Can you tell the name of the further investigation, one or two investigation which you need to do in this patient, those who have BRCA1 positive?
Sir, I think biopsy.
Biopsy. So why you want to do a biopsy in a patient who is a normal? I mean, he has a no ovarian mass, he has a no adnexal mass. Physical examination does not show any abnormality. Patient is fine, right? Patient vaccination is fine. It is up to date. Patient has no complaint. He has just only concern. Say, for
Then
example, my father has a
every
diabetes, so I'm concerned about diabetes. I don't have any problem. That's it.
yes,
I'm
uh,
absolutely fit and fine.
sir,
Why you want to do the biopsy?
for every year to do the investigations like transvaginal ultrasound and different managements every year. If now she is healthy, to do every year investigations, routine checkup every year if there is
Fine.
any changes.
So your concept in this patient, you first do the BRCA 1 and 2. If it is positive, then every year you gonna advise her for annual vaginal or transvaginal and ultrasound and CA125. Is that the
Yes, sir.
answer?
Yes, sir.
Fair enough. Fair enough.
And,
Let me
uh,
understand. Let me
excuse
understand
me,
from
sir.
another
I
doctor.
think we should perform familial risk assessment simple using a questionnaire. Nothing else. Because the age is, the mother has at the age of 63. So, and the patient is now at the age of 40. So if
Okay.
you resist assessment, it should be the at least 10 years when her mother, below 10 years when her mother was diagnosed. Approximately
Fair
53.
enough. So 53, you wanna do something more aggressive for this lady to get the idea. So what could be the
I think
answer
we
right
do
now? What
just familial assessment, I think.
familial risk assessment using a questionnaire? Fair enough. Let's see. Yes, Dr. Zara Baba Bukar, what do you think? It's an interesting question. No? Very interesting. How you gonna approach this patient? Yes,
Um,
doctor.
yes, sir. I think um, A is the answer because maybe we need a general, not only because her mother has ovarian cancer, but we need to use a questionnaire to see the percentage so that we can choose what to do next.
Wonderful. Excellent. So what questionnaire do you think? What questionnaire you will ask to this patient? And how you assess the familiar risk assessment? Right, so is there any test or you just by asking the questions, or what exactly you do in perform familial risk assessment using a questionnaire? So what questionnaire could be there in the list of this patient? What you gonna ask them, or how you gonna questionnaire them? Any idea? Any idea? Yeah, Zara.
I don't know the name of the questionnaire actually.
Yes,
No
sir.
problem. Yeah, anybody, I mean, it's a learning platform, no? So I would be
I
happy if
also,
you interact. Yes, anyone?
I think the first question, which relatives have had cancer, first or second degree relatives, like parents, grandparents, like this. And the second question should be what types of cancer were diagnosed and which,
What type of ovarian cancer? Means you mean to say histology of the ovarian cancer?
you know, what kind of cancer? I mean, ovarian, breast, maybe some other.
Fair enough. Fair enough. Because ovarian may have some breast, ovary, pancreas, this they all have BRCA1 too, right?
And the especially moment is the ages, very important. Before 15 or after something like that.
Mm-hmm. Fair enough. Fair enough. So homework for today for everyone, don't take it otherwise, right? Read the ovarian cancer in detail. Lots of question comes in ovarian cancer. How you diagnose ovarian cancer? What are the investigation of ovarian cancer? What is the screening method of ovarian cancer? And basic treatment. I mean, if somebody gets ovarian cancer, how you gonna treat? That's it. Simple. Very not much. And how the ovarian cancer or breast cancer or pancreatic cancer and recently the prostate cancers are related with the BRCA1 and 2. Go and read it little bit. Try to do some more exercise, get out of the comfort zone. You learn a lot of things and probably that helps in your exam. You may see the question in front of you in exam, so it will be definitely going to helpful. Yes, Dr. N, would you like to comment anything on this, Dr. N? And then we'll go to the real next answer.
Good afternoon, sir.
Very good
I was
afternoon.
thinking of performing genetic testing and then go for transvaginal if we find it positive. If we
Okay,
find BRCA positive.
okay, fine. So BRCA positive, if positive, then you go for the transvaginal ultrasound and measurement of
Annually, sir. Yes, sir.
CA125.
Because she's just
Right.
40 years.
Okay, so if BRCA is not negative, say for example, you don't want to advise anything to the patient because BRCA is positive rarely in the patients, right? So I'm seeing
HPV
just
vaccination.
my experience I'm sharing right away now. I'm probably seeing I can say 25 to 50 ovarian cancer a year, roughly. So probably one or two month. If two a month, then at least 25, 30 ovarian cancer I'm treating every month for last 20 years. So BRCA1 and BRCA2 we do regularly. We do the NGS, next generation sequencing, in which we do the BRCA1 and 2 and few other molecules, right, which is targeted. So say for example, I have very rarely seen BRCA1 is positive. So if this mother 63, we don't know what is the BRCA status. Do we know? Is it
No.
mentioned in the scenario that
No.
BRCA is positive for this female? Her mother was diagnosed with the ovarian cancer at the age of 63, right? So when there is nothing mentioned, means she probably negative. She probably negative, right? So it is not mandatory that all the ovarian cancer 100% have BRCA. Hardly 5-10% have BRCA positive. Most of
So
them they have
answer
BRCA
would be D,
negative.
sir.
No, so answer is not also D because why you want to do a ultrasound or transvaginal ultrasound in an asymptomatic patient at the age of 40? Why you want to do? Patient is asymptomatic. Patient first line is what? Listen, this is all catch and clues in the MCQ. That is what we need to learn, right? So what's the 40 years female woman comes to the physician for a routine health maintenance. Means she wants to check that I'm fine. Like I'm every 6 monthly I myself, right? Every 6 monthly I myself do the workup myself, right? That okay, fine. My hemoglobin, cholesterol, 2D, CBC, thyroid functions, kidney function, liver function, renal function, cardiac functions are normal. So this is called health maintenance examination, right? So that means she's fine now, absolutely fine. She's just walking into the physician room, right? Just to with the concern that mother has 63 years of age, ovarian cancer. What I supposed to do? Are you getting me? Yes or no?
Yes, sir.
Right, so she's fine. I mean, she's fine. So in a fine patient, some fine patient comes to your OPD in walk-in, are you going to advise transvaginal ultrasound who is asymptomatic, otherwise fine?
No.
No.
Usually no, obviously no. Obviously no. Some walk-in patient comes to your OPD and father died of coronary artery disease. Are you going to advise them, okay, right away we do the angiography for you? Yes or no?
No.
Hello?
No,
No,
sir.
obviously he's fine. He's concerned that my
No,
father
answer
has a
is
heart
A.
attack, my grandfather has a heart attack. I'm concerned. I'm concerned about heart attack. So what I supposed to you, how you advise them? You do some basic things, you advise lifestyle changes, you do the risk assessment, you do something smoking, alcohol, hypertension, obesity, dyslipidemia, and try to assess the risk. Right? It is a high risk, then you advise something, but you will not directly jump into the angiography or invasive things. Isn't it? Yes or no?
Yes, sir.
Excellent. So here just the answer. Answer is this.
A maybe.
Yes. So that's the answer. So now we'll discuss more with this answer A. 1 second. Huh? Yes. So here the answer is screening recommendation in the context of cancer susceptibility due to BRCA mutation vary. The US Preventive Task Force recommend a woman with a personal history of breast cancer, ovarian cancer, tubal cancer or peritoneal cancer or positive family history for this type of cancer undergoes familiar risk assessment with a standardized questionnaire. The risk factor for ovarian cancer evaluated by the risk assessment tool including personal family history of ovarian cancer, breast cancer and certain other type of cancer, especially the bowel at the age of the age of the diagnosis. Age at the diagnosis and number of relatives affected. And as an is Jewish descent, if it is Jewish descent, there is a more risk of developing this. So you need to ask the history. These all are questionnaire. If the result of this risk assessment tool is positive, then genetic counseling, and if indicated after counseling, genetic testing for BRCA1 or 2 mutation should be followed, right? So screening of ovarian cancer is not routinely recommended for the women who do not have personal or family history of the above mentioned type of cancer because of lack of evidence that supports such screening. Patients who are known BRCA1 carriers and do not wish to undergo preventive bilateral salpingo-oophorectomy may be offered periodic screening of ovarian cancer in terms of transvaginal ultrasound and CA125. Is that clear? Is that clear?
Yes, sir.
Right? So you are thinking by and large the in a proper way, but first is to assess the risk and then you do the BRCA genetic test, right? If it is positive, the best treatment, if it is positive. So say for example, this all are exam question, huh? They will come in a different way. We are discussing all, right? So some patient has a mother has a CA breast, CA ovary, right? Daughter is at risk, right? She is 63, but say for example, now she is 53. You do the BRCA is positive. Treatment is you can do the prophylactic. Here it is given clear cut indication, right? Here ovarian cancer and it's all positive, right? They should go bilateral salpingo-oophorectomy. The ideal treatment is bilateral salpingo-oophorectomy, right? If patient does not wish to go for this, then you do the periodically monitoring transvaginal ultrasound and CA125, right? Especially in high risk, those who have mother died of ovarian cancer, those who have BRCA1 positive. This is extremely high risk of development. So before it develops, you do the surgery. Before it, right? If they don't want to go for surgery, close monitoring. Same way with the BRCA breast. Mother has a breast cancer. Daughter has a high risk of breast cancer. Daughter did the BRCA. Daughter has a positive BRCA. Treatment is bilateral prophylactic mastectomy. If don't want to go for this, clinical breast examination, breast self-examination, a regular close mammogram is absolutely mandatory to detect in a very early stage. Detect in a very early stage. Here, why you want to do to detect in a very early stage? Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
And this is the biggest example of this is Angelina Jolie.
Sir, can you repeat it?
Angelina Jolie is a Hollywood star, probably the wife of Brad Pitt. She is a young, famous, top 10 popular heroine in the Hollywood. She has the same problem. Family history. She has a BRCA1. She did a prophylactic mastectomy before cancer develops, and then she did the silicone implant. Go and read the story in the Google. The same case. And after this event, globally the burqa was so popular that now people knows what is burqa 1 and 2, what is a genetic inheritance, how burqa is related with the breast cancer after prophylactic mastectomy of Angelina Jolie. Go and read little bit in detail. Yes, please. Any question? Any question? Fair enough. No questions means I'll go ahead. Is that clear to everyone? Yes or no? Yes or no?
Yes, it's clear. Thank
Wonderful,
you.
wonderful, wonderful. So go and read. Second homework is a BRCA and breast cancer and ovarian cancer, right? So this is absolutely high yield questions for prevention, for management, right? And global statistic is that the leading cause of morbidity and mortality or top commonest cancer in female is a breast, cervix, and tubo-ovarian. So it's a high demanding questions globally, right? And lots of patients we see being a medical oncologist, hematologist in our practice every day for ovarian, tubo-ovarian, and breast cancer. So we must know each and everything, right? Bit in detail, right? If you don't know anything much in detail about pancreatic cancer, colorectal cancer, or skin cancer, that would be fine, happy. But breast, cervix, and ovary, absolutely you need to know each and everything. So that's homework. Let's jump to the next question. A 14 months old boy is brought to the physician by is now switch the gear from hematology, oncology, pediatric. So this is pediatric. 14 months old boy is brought to the physician by his mother because of abdominal bulge that has become more noticeable and has begun to walk 2 weeks ago. Bulge increases on crying and disappearing when he is lying down. He was born at 39 weeks gestation by lower segmental transverse section or lower CS. He has met all the developmental milestone. He has been breastfeeded well since birth. He appears healthy and active. Vital signs are within normal limit. Examination show a non-tender 1 centimeter mid-abdominal mass that is easily reducible. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the management? Emergency open repair, elective open repair, reassurance and observation, abdominal ultrasound, elective laparoscopic repair, CT scan of abdomen and pelvis. So think over it. Don't be in a hurry. Don't be in the hurry, even in exam. This is the key to success. Make a diagnosis. Ask yourself what is the investigation of this scenario and treatment. 3 question is mandatory for each MCQ. So they have given patient's history, examination, blah, blah, test. They had not given the diagnosis. So make a diagnosis. We don't have the diagnosis here. If you make a diagnosis, the next step is the little investigation plus treatment is equal to management. So they are directly jumping on the management. But without diagnosis, how you gonna jump on the management? So make some diagnosis in your mind what this baby is suffering from.
Sir, this is
Yes.
this is an umbilical hernia.
Excellent.
And
Wonderful. Umbilical hernia. Wonderful. Wonderful. It's the answer. That is umbilical hernia is the answer. Right. So now what and how you want to treat? Next step in the management for this patient is what?
sir, reassurance and observation.
Reassurance and observation. Why you don't want to operate this patient?
Sir, because it will close simultaneously. Most probably, maximum cases, it closes by its own. We will wait for 2-3 years. If it is closes and good, if not, then he will go for the surgical.
Fair
He's
enough. So
14 months old only.
fair enough. Fair enough. Let me check with other because everybody has a different answer. Yes, Mr. Arif, Saba Aisha, what Dr. Boni, what's your comment? How you gonna treat this patient?
Yeah, reassurance and observation. We will wait for 2, 3 years of age.
Fair enough. Fair enough. Fair enough. So few other answer D, abdominal ultrasound. So yes, Dr. Boni, Dr. Safa Aisha, what's your comment? How you supposed to deal with this patient?
Confirm the diagnosis with abdominal ultrasonography, sir, and then
O-
go for the.
Okay, so say for example, this is a classical of umbilical hernia. Are you agreed with this or not?
Yes,
Clinic,
agree.
clinically,
Yeah,
it is umbilical.
clinically it's umbilical hernia. So I'm asking what additional information will get by doing the ultrasound. Say for example, you did ultrasound, and ultrasound is also confirmed that it is umbilical hernia. Then what is the next step? You did it
Uh,
ultrasound. Okay, fine. You did it,
Reassurance.
right? Then radiologist is saying and giving the excellent report, sir. This is umbilical hernia in 14 months of boy. Now what's your next step?
Reassurance, sir. We don't do surgery for this patient.
Reassurance. So why can't you give the reassurance first? As patient is not a complicated, is not obstructed hernia, it's not obstructed these things. Patient has no fever, no vomiting, no abdominal distension, no constipation, playing right, and he's saying while he's crying, it's bulge and he's lying down, it disappear. Completely clear cut picture. Breastfeeding is well, a milestone is well, and this is a picture, this is a picture, this is the picture. So what additional information you gonna get by ultrasound or CT scan or by some investigation? Nothing much. So here in this case you better, when the diagnosis is clear, clinically clear, you don't need to go much in detail of investigating the patient. When absolutely is clear cut, transparent, classical, you can wait and watch. The vast majority of the congenital umbilical hernia close spontaneous. This is all official literature from the standard international textbook. The vast majority of the congenital umbilical hernia close spontaneously by the age of 5 because the patient is asymptomatic and the hernia is a small. Most appropriate management at this time is reassurance and observation. The risk of complication, incarceration, strangulation is low in comparison to the other types of type of hernia in umbilical hernia. If the patient develops feature of bowel obstructions such as a constipation, vomiting, insistent crying, or hernia does not decrease in with the time, surgical repair may be indicated. That's the literature. Any comment? Any comment?
Clear, sir.
Excellent. Clear means I go ahead. Why not emergency open repair? Because there is nothing emergency. Elective open repair is answer when it is not closed. Abdominal ultrasound, umbilical hernia diagnosed by clinical evaluation, and abdominal ultrasound would be performed to evaluate complication. But the absence of hernia, tenderness, erythema, pain, nausea, vomiting, or peritonitis makes this strangulation. In absence of this, abdominal sonography will not help. Is that clear? Yes or no? Yes or no?
Yes, sir.
A 32-year-old woman, gravida 2, para 1, at 32 weeks gestational, comes to the physician. It's now switch your gear from hemat on pedia and now this gynec. All. So you check your knowledge overall. That is why I selected all different department question. 32-year-old woman, gravida 2, para 1, 32 weeks gestation, come to the physician for a prenatal visit. She reports that she has had frequent headache, dizziness recently. Pregnancy and delivery of her first child was uncomplicated. There is no personal or family history of serious illness. Medication includes folic acid, multivitamin. Her temperature is 37 or normal, pulse is 90, looks okay. Blood pressure is 170 over 100. Pelvic examination shows uterus consistent in the size with 32 weeks of gestation. Fetal heart rate is 155 per minute. Now you look at the lab, hematocrit is 37, little lower in pregnancy. Leukocyte is 9,000 per cubic millimeter, platelet is 60,000. Serum sodium is 140, chloride 104, potassium 4.4, creatinine is 1, asparginase, uh, aminotransferase, SGPT 35, SGOT 38. Which of the following is most appropriate step in the management of this patient? Magnesium sulfate and labetalol therapy, platelet transfusion, induction of the labor, lisinopril therapy, ICU admission, cesarean delivery. Take your time. Let me, before you forget anything, let me give my triad.
Sir,
First,
even
look
though
at
the patient
diagnosis.
is normal, I feel this patient can be pre-eclampsia due to high BP. Therefore, I would like to give her magnesium sulfate and labetalol therapy.
Well,
I think, sir, the induction of labor will be ideal at this stage.
think what's the answer?
Sir, I think the induction of the labor.
Sir, is it a case of ITP, sir?
It's a HELP syndrome, most probably.
Okay, so now what's the diagnosis? Simple question, first of all. All differential you can put it here. First one.
It's severe
Thrombocytopenia.
preeclampsia.
Preeclampsia, yeah.
One is pre-eclampsia. Okay. What is second?
Thrombocytopenia.
No, sir,
must be-
it could be
No.
most probably HELP syndrome, I think.
HELP.
It could be HELP syndrome. Okay.
Can it be ITP, sir?
HELP syndrome. Third is ITP. Fourth, it's a learning. So we'll learn. We'll exclude one by one. Then you develop the concept. No? Whatever you are telling me, I'm making a list of the things. Yes, anything else? Anyone else? So who has the answer? HELP syndrome?
Yes, sir, me.
Okay. Yes, Dr. Vani. Hemolysis, elevated liver. So now in HELP syndrome, what it comes in the HELP syndrome? H means hemolysis.
Yes, sir.
Hemolysis,
E,
elevated liver enzymes, and low protein.
elevated liver
Enzymes, low protein.
and low, not low
Platelet, sorry,
platelet.
platelet.
Fine.
Okay.
So Dr. Vani, can you tell me, do you see hemolysis in this patient? Yes or no? First of all,
Yes, it's, I have not seen.
if you see, just tell me where you can see the hemolysis or signs of hemolysis or symptoms of hemolysis. Yes, tell me. Yes or no?
Hematocrit is low.
Fine.
So
So
only
this is
hematocrit is there.
so see, there is no evidence of anywhere hemolysis mentioned in the scenario. So no hemolysis. Elevated liver enzymes are not there. The range is up to 40 is normal. This is up to 40 to 50 is normal. So both are normal. SGPT, SGOT. This is liver enzyme. Yes or no? At least tell me yes or no.
Yes, sir.
So this is also normal. So still, do you think that this is a HELP syndrome? Low platelet is there, but low platelet always is not HELP syndrome. No? Is that clear? And
Yes,
can you
sir.
tell me, Dr. Vani, what is the hallmark of HELP syndrome? Hallmark symptoms of HELP syndrome. Anyone? Open for all. Exam question. Hallmark symptoms of HELP syndrome includes what? So two things includes in HELP syndrome: right upper quadrant or epigastric pain. It is one of the hallmark. Why? Because of liver distension in pregnancy. This is the hallmark. If some patient pregnant tells right upper quadrant or epigastric pain with liver distension, right, right. So this is the hallmark, and along with that, nausea, vomiting, edema, headache, jaundice because of elevated liver enzyme is there. If you can see in the scenario, nothing, absolutely nothing is there. So by my sense, help is gone. Are you agreed? Yes or no?
Yes, sir.
Excellent. ITP. Who told ITP? Sorry, I mean we have a lot of people, so I can't remember each and everybody's name. So who
Safa,
told ITP?
Safa,
Yes. So
sir.
yeah, Safa. So just for your discussion point, why ITP? And do you think in ITP there is a 170 over 100 blood pressure in ITP? Do you think ITP patient should have this? Do you think the patient
Yeah.
has a frequent headache in ITP?
We
Do
hear
you
you,
think
Dose boy.
patient
I
has
think
a
yeah.
dizziness recently in ITP? Right? Do you think this is the thing in ITP? Yes or no?
No, sir. Most of them are not associated. So she might be a patient of
So preeclampsia
epilepsy.
versus ITP, preeclampsia versus ITP. How you differentiate preeclampsia versus ITP? So
Multiple patients with
hypertension. So pregnancy must be there. Number one, right? Pregnancy must be there. Number two,
Headache,
preeclampsia. Patient has a proteinuria.
BP.
Patient has a hypertension. Right? Patient may have pedal edema, which is not there. Patient has no proteinuria. Patient has no hypertension. Patient has no edema. Most of the patients are non-pregnant, right? But ITP can happen in pregnancy. It's possible, right? But these things are not happen, right? So this is less likely ITP, right? So now
their
the
urine,
answer close to be preeclampsia.
urine protein is not mentioned in the question, so I took it as negative, sir.
Fair enough. But this is classical of because ITP never see. Let's go to the question. 32-year-old woman, this gravida para physician prenatal reports a frequent headache. So whenever there is a headache in pregnancy, must think of hypertension, right? Is not
Yes, sir.
seen in ITP. Dizziness recently, pregnancy and delivery of the first were uncomplicated. There is no other things, no things. So blood pressure is one of the most important things here to differentiate at this gestational point, 32 weeks, right? So preeclampsia, how finally you compiled or diagnosed or define preeclampsia? What is the definition, simple definition of preeclampsia?
Urine protein is
If
Sorry.
preeclampsia.
BP is more than 130, and if presence of proteinuria, pedal edema, headache, or dizziness during gestational, it is can be considered as preeclampsia.
Okay, so preeclampsia, let me ask you, the blood pressure increase, hypertension or high blood pressure develops beyond how many weeks of gestation as per the definition? What? So gestational age of 12, gestational age of 20 weeks, gestational age of 36 weeks, or gestational age of 24 weeks. At what age, as per the definition, if the patient, pregnant patient, hypertension, it was called as a preeclampsia?
20 weeks.
20 weeks,
Are you
20
are you
weeks.
get are you getting my question or not? Yes.
Yes, sir. Before
Yes, sir.
20 weeks,
Wonderful.
20 weeks.
chronic.
Yes. So as per the book, it's a 20 weeks. So definition is that the preeclampsia is a serious pregnancy complication characterized by hypertension, right? And hypertension, right? Characterized by the high blood pressure, right? And typically develop beyond 20 weeks of gestation or pregnancy. This is two key important things. Two key important things. Any pregnant woman who develop the hypertension beyond 20 weeks until proved otherwise preeclampsia. Rest of the things that can be there, right? So this is what the thing is. So they may have protein in the urine, right? And lot more things, but this is the things. So now what could be the treatment of preeclampsia? So say for example, preeclampsia develop at 30 weeks, develop at 32 weeks, develop at 34 weeks, develop at 36 weeks. Is there any change in the management of the patient? Or let's little go beyond it, more than 20 weeks now, patient at the 24 weeks. So if this all five different question comes in exam, how you gonna monitor? Patient has a hypertension, more than 20 weeks of pregnancy. One lady is at 24 weeks. What's your advice? One at 30. What's your
36 weeks,
advice?
you can deliver the patient.
Okay, so this is clear work. But 36 weeks you can deliver the patient or deliver the
Post
baby.
Before that, you have to give surfactant. Before that, 34, you have to give
So up to
surfactant,
what
MGSO4
surfactant? Why you want to give surfactant?
for the
Steroids
lung
for
maturity of the patient and steroids.
they give steroids for the surfactants to produce. Don't give surfactants.
Okay, so in which age group? 24, 30, 32 or 34? I
32
give
to 34.
32 to 34 surfactant I need to give, right? Surfactant.
MGSO4, steroids, and surfactant.
Progesterone
Surfactant,
you have to give, sir, for the production of
MG, MGSO4. Why you want to give MGSO4 to this patient? Patient is not in eclampsia, it's still in the pre-eclampsia.
To prevent.
Sorry,
To prevent.
to prevent. So is it a guideline that pre-eclampsia, all patients of pre-eclampsia should receive MGSO4? Yes or no? Any gynecologist here, they can better answer.
Dexamethasone is given for lung maturity. But magnesium sulfate, nowhere it's indicated.
Sorry?
Dexamethasone is given for lung maturity, but
Mhm.
we do not administer magnesium sulfate here.
Fine. So homework is to read the treatment of preeclampsia. Preeclampsia. Complete treatment of preeclampsia. Beyond, as per the definition, hypertension and beyond 20 weeks. So read in such specific way. What if it is 24 weeks? What if it is 28 weeks? What it is 32 weeks? And what if it is 36 weeks? And what if it is beyond 36 weeks? Is that clear? Yes or no? Probably if you do research, some answer probably change. What is the drug of choice to control this blood pressure? Another question in exam. Which is the
Labetalol.
drug of labetalol?
IV labetalol. It's a hypertensive crisis.
Right. Okay. You don't want to give methyl dopa? Hello.
No, sir.
Methyl dopa, you don't want to give methyl dopa?
There are old criteria, no, sir.
Okay. Old criteria. Interesting. Old criteria. Fine, fair enough. So what is the new criteria then? What's the new criteria?
Labetalol.
Labetalol. Okay. It's a which group of drug?
A non-specific beta antagonist. Alpha and beta antagonist.
So beta blocker, non-specific beta blocker. This is what you mean to say, sir? Yes
Yes,
or
sir.
no?
Both alpha and
So now,
beta.
so labetalol is alpha and beta. So what are the specific beta blocker then? By you, it's a non-specific.
Atenolol.
So this is homework. Read the beta blocker indication. Indication of beta blocker in clinical practice, especially the hypertension, angina, and arrhythmia. Beta blocker has three major indications. It is anti-anginal drug. It is anti-hypertensive drug. And it is anti-arrhythmic drug. Because in arrhythmia, we give the beta blocker post-MI. hypertension, we are giving labetalol. And in acute myocardial infarction, we also give beta blocker. Isn't it? Yes or no? Yes or no?
Yes, sir.
Go and read it. It's a very interesting chapter. We'll discuss sometime. So answer for this question is a magnesium sulfate and labetalol therapy. This patient is of this preeclampsia, not a ITP, not a HELP syndrome, right? So we need to treat them, right? So magnesium of preeclampsia, management of preeclampsia, right, with severe features is determined by the gestational age, hemodynamic stability of the mother and the fetus, and complication in the pulmonary, hepatic or renal of the mother, pulmonary edema, oligohydramnios, gestational age less than 34 weeks, and both mother and fetus are stable. As seen here, expectant management with a conservative treatment is appropriate. However, an attempt to delay a delivery beyond 34 weeks gestation will increase the viability of the fetus and therefore appropriate for this patient. Conservative treatment includes a magnesium sulfate, sorry, for the prophylaxis of eclampsia and antihypertensive, labetalol. Dexamethasone should also be administered in order to induce the fetal lung maturity, which will reduces the risk of neonatal respiratory distress syndrome, intraventricular hemorrhage, and neonatal death. Additionally, the patient should be closely uh, monitored in a facility with both an adult and neonatal ICU. In patient with preeclampsia with the severe features beyond 34 weeks of gestation, immediate delivery after stabilization is indicated. Is that clear to you all, yes or no?
Yes, clear.
Yes, sir.
Wonderful. So I had given you the homework. Let's stop here. I'm speaking for almost 1 hour and 25 minutes, beyond that as well. So once again, thank you very much all for your kind attention today, and we will come up with a lots of questions in the next Sunday as well. So I would like to have a very quick feedback. I would be glad and happy if you what you learned or something new for you today that makes me more fascinating. Any comment
Hi, sir.
in the audience?
My name is Anne. I just want to thank you for that AML, CML, CLL, leukemias, because they were always confusing for me. No matter how I read it, those concepts used to be so confusing for me, but you made it simply superb and crisp. And for me, and you gave your own version of things. So it was really that time, that tabular column. So that was really helpful. Thank you so much, sir.
Excellent. Thank you for your kind feedback. And as usual, anyone else in the class? Anyone else? Dr. Bonnie, any comment?
Yeah,
Yes, sir. Please.
leukemias were because I'm little good in surgery and gynecology. So yeah, leukemias were very helpful for me. Thank you so much.
Wonderful. Feel free to drop me the message directly. No worries. I'm an expert hematologist, so I will. Hemat is easy for me.
Thank
Fair
you.
enough. Anyone else? Any comment? Dr. Zahra, Dr. Nasini, Dr. Boni, Dr. Bhavya? I think you have no audio. I can't speak, sir, outside. So fine. Thank you very much. No problem. Any other comment? Dr.
Yes,
Samuel?
for me also the leukemia, actually, it was very hard for me to differentiate. But now I think I can answer questions when
Wonderful.
it is about leukemia. Yeah, thank you.
Wonderful. Yes, Dr. Vani, Dr. Nahid, Dr. Kainath. Any comment if you are in
Yeah,
class,
Dr.
Sidra?
Munjal, thank you so much. Hello.
Yes, please.
Hello.
Yes, we can hear you, doctor.
Yes, thank you so much for taking your lecture because we don't get decisions about it much. Most of us always we are getting confused with the topics and we are not able to hear myself. And it is always confused. This motivation is always confusing for a student, for the doctors. It is like that as we are in that. So, thank you. you
Great,
so much.
wonderful.
I have just one suggestion, doctor,
Yes.
possible suggestion for, because I know that is a real exam. The question is coming as a real exam like that, all makes sense.
Your mic
But
is bit low,
for
doctor. I don't know
I have
whether
a
to me or all.
suggestion.
Make it little closer,
Yeah,
your mic.
yeah. One.
Yes.
Hello.
No problem. So,
Yeah.
yeah.
Is it okay now?
Yeah, little disturbance probably from your
Yeah,
side.
like for example, today it was a hematology, no? The question all about a one subject. Clear was a one system hematology. If you are going to as a system wise, it will be very helpful for who are in this journey preparation for this whole country exam. Because when we are going to the mix, we are getting who are in the starting preparation, no?
Great. Yes, Dr.
Because it
Safa
was suitable.
Aisha.
It was very helpful. It was very helpful.
Thank you. Thank you very much for your kind. Thank you very much.
Sir,
Yes, Dr.
every time when we attend your mock test, we just realize we still have so much to read. There is so much of different
So,
diagnosis.
so I'm not a good person.
No, I mean, we read and we think that it's almost done, but again, when we come to the class, there is so much new to learn again. So it's always new in your class. It's nothing like you repeat the same stuff or you say something which you already know. There's always a learning in your class, no matter how many classes we join. That's really good part of your classes. So.
Thank you thank you very much for your feedback. Yes, Nirja, how it helps all to your pathology. Dr. Nifra, Sherin, Reshma. Yes, yes, Murod, any comment? Last but not the least.
Yes, sir. Thank you very much for your help. Your unique explanation, simplified all topics is really good for us to learn. Each time in each mock exam, we learn a lot of things from you. Thank you very much.
Thank you, sir, for your feedback. Thank you very much. Okay, so I think we'll stop it here and let's join again next week with the more detailed explanation and new, but try to do the homework what I had given you. And thank you very much and stay tuned. You can put your feedback in comment as well. Thank you very much and enjoy your Sunday. Thank you. Thank you very much.
Thank you.
Thank
Thank
you,
you,
sir.
sir. Thank you. Take care.